We know that there are trials of BRAF plus MEK inhibitors combined with PD-1 antibodies altogether planned. We know that there are trials of BRAF and MEK combined versus immunotherapies combined in 2 different patient groups, and then they cross over to the opposite arm at progression. We know there are trials of BRAF inhibitors plus AKT inhibitors, that's the PI3 kinase pathway. We know there are trials of BRAF inhibitors plus PI3 kinase inhibitors. So that's the BRAF mutant space. In the BRAF wild type space, we know that there are trials of MEK inhibitors plus cyclin DK4 and 6 inhibitors. That looks very exciting as well. That's for both BRAF wild type and NRAS mutant melanoma. So they're the sort of groups that have been looked at. We know that there are plans for BRAF or MEK inhibitors combined with MDM2 inhibitors. These are drugs which inhibit P53. About half of the melanomas have P53 intact, so they would be appropriate for those sort of trials. And that's for both BRAF mutant and wild type. And we've also got trials planned of BRAF inhibitors plus receptor tyrosine kinase inhibitors. I don't know that that strategy is the first one I would go for, because I know receptor tyrosine kinases are at the top of the pathway, and inhibiting at the top when you've got so many pathways descending on one protein low down may not be the best strategy, which is why I sort of favour the immune approach or the AKT PI3 kinase approach, or in fact the cyclin 4 and 6 inhibitors, or even the epigenetic inhibitors. So histone deacetylase inhibitors are very exciting as well. But toxicity may be an issue with those, we just have to see.